Good evening, everybody, and warm greetings from the United Arab Emirates. We are gathered here today in yet another wonderful webinar organized by the Emirates OBGYN Society on the new frontiers in management of anemia, more specifically anemia in pregnancy. Anemia in pregnancy complicates women from high to low medium income countries and has got a prevalence rate of 42% in high income countries to up to 73% in low to medium income countries. The Royal College of Obstetrics and Gynecology defines anemia in pregnancy as in a non-pregnant woman with a hemoglobin less than 12 grams per deciliter in the first trimester of 11 grams per deciliter, in the second and the third trimester of hemoglobin concentration of 10.5 grams per deciliter, and in the postpartum period, a hemoglobin concentration of 10 gram per deciliter. Before we proceed with our wonderful speakers who have gathered here, I would like to thank them for giving their valuable time in educating us about the new frontiers in the management of anemia. I would like to remind everybody that we are live streaming. The webinar is live streamed on MCI Middle East channel, YouTube channel, and it's an on-demand webinar, and the webinar will be available on demand in the MCI Middle East YouTube channel. Type in your questions in the Q&A box and also mention the speaker name. And this CME is accredited by Ministry of Health and Prevention. And we also have live chat support available on WhatsApp during the event at the number displayed on your screen. Next slide, please. Good evening. My name is Dr. Amala Nazareth, and I am an obstetrician and gynecologist working with the Prime Healthcare Group. I also happen to be the member of the Emirates OBGYN Society of United Arab Emirates, and I'm here to welcome two eminent and respected seniors who have done years of work in this field that we are going to speak about. One of them is Professor Hema Divakar, who is going to be speaking on revisiting anemia care and the use of lactoferrin. And our second, but not the least speaker is Professor Michael Auerbach, who is going to be speaking on the management of iron deficiency anemia in pregnancy. I start with Dr. Hema Divakar. Dr. Hema Divakar is a leading medical professional of India with a vision to improve healthcare service ecosystem for the welfare of women. An accomplished specialist in the field of OBGYN care, she is the medical director at the Divakar Specialty Hospital in Bangalore, a center of excellence for women healthcare and center for skill enhancement. Her positions of eminence is that she currently holds an exhaustive list of important positions of great responsibility within the country as well as within the world. She is a technical advisor to the Ministry of Maternal Health and Family Welfare. She's also the CEO and chairman of Asian Research and Training Institute for Skill Transfer. She's the national coordinator for the Foxy Quality Initiative for Safe Delivery, Manyata. She is the vice chair of the PNCD committee at FIGO. She is also the national coordinator for the FIGO Foxy WDF program. Her awards are numerous, but among them are FIGO Women Achievers Award. She's the Icon of Healthcare Award from Singapore. She's a recipient of the Social Entrepreneurship Award from UNAIDS and MSD. And she has a Lifetime Achievement Award by the Diabetes and Pregnancy Study Group of India, Asia One Award for the Great Leaders in India, and Global Asian of the Year 2018. So I present to you Dr. Hema Divakar. But I would also like to introduce our second speaker. Professor Michael Auerbach is from the United States. Professor Michael Auerbach is a hematologist and an oncologist at the Auerbach Hematology and Oncology Associates Incorporated in Baltimore, Maryland, and a clinical professor of medicine at the Georgetown University School of Medicine in Washington, D.C. He graduated from New York Medical College in Valhalla, New York, completed residency in internal medicine at the Cleveland Clinic Foundation in Ohio, and hematology and oncology fellowship in the Columbia Presbyterian Medical Center in New York. And he is a board certified internal physician, hematologist, and medical oncologist. He has authored close to 185 journal articles, books, chapters, and abstracts, and most recently focused on intravenous iron supplementation in pregnancy, restless leg syndrome, and bariatric surgery. He authors The Treatment of Iron Deficiency Anemia in Adults, Anemia in Pregnancy, and Diagnosis and Causes of Iron Deficiency for Up to Date, and a fellow of the American College of Physicians and honorary emeritus member of the American Society of Hematology. He's on the editorial board of the American Journal of Hematology, Blood Transfusion, and Expert Review on Hematology. In December 2017, he published the American Journal of Medicine, the first prospective study of intravenous iron in pregnancy in the United States. I now hand over the stage to Professor Hema Divakar, who is going to be speaking on revisiting anemia care, use of lactoferrin. Thank you, Madam.
Namaskar. This is Dr. Hema Divakar, a senior consultant OBGYN from the Divakar Specialty Hospital, currently the chair of the FIGO Well Women Healthcare Committee, speaking to you from Bengaluru in India. We are speaking about the new frontiers in the management of anemia and revisiting and doing some fresh thinking on the role of lactoferrin, both in the iron deficiency anemia and immunity. My role is to revisit the anemia care with the use of lactoferrin and how we have strategized the care of anemia through the journey in adolescence, reproductive, and the menopausal age group is what we are going to take you through. So in the country context, we have about 20% of maternal deaths caused by anemia alone, and we reflect very sadly on the preventable deaths due to anemia, which could have been well managed during her pregnancy and ideally even before she embarked into the pregnancy. The LMICs, that is the low middle income countries, would dream of not talking about anemia as a perpetual menace, but as on today, this dream has not turned into a reality. Despite great efforts by every government in the LMIC and despite the best efforts of the clinicians, anemia still holds a tight grip on our populations. Well, to reflect back in our own country context, it was way back in 1972 that the government launched the National Nutritional Anemia Prophylaxis Program, but it was sort of a knee jerk for a segment of the pregnant and lactating women. The entire thinking process has changed in the recent past, and the relevance of every age group which needs to be tackled and the approaches which are now multi-sectoral beyond the OBGYN community has come into place. The approach therefore now is also food-based with the dietary diversification and the food fortification. The supplementation of the tablets, capsule, syrup, injection, of course, remain the mainstay, given the limited time in the reproductive age group and the public health measures, which matter very, very significantly about the sanitation, hygiene, health education, and communication for the behavior change. Irrespective of the cause, needless to say that anemia during pregnancy has been witnessing very, very serious adverse maternal and neonatal outcomes, and it is as if anemia adds fuel to the pregnancy complications. The general complications such as fatigue, palpitations, tachycardia, hypotension, and pallor are the base, but the maternal risks of increased preterm delivery, antepartum and postpartum hemorrhages, failure of lactation, puerperal sepsis, and prolonged labor and failure of induction form a large group in the anemic women who are on their journey for pregnancy and delivery. The fetal risks are also in plenty. The growth restriction, the low birth weight, the intrauterine deaths, neonatal anemia, and the risk of infection even in the newborn. Prematurity with respiratory distress syndrome continues to haunt in the undernourished and anemic population. If you see a rather busy slide here, every other complication, when you compare an anemic to a non-anemic women, is escalating, and there is enough and more evidence that the opportunity to treat the anemia should well have been taken before. Not that it's a rocket science, not that we don't know what to do beyond the rich iron diet, which we can advise to all our patients. The oral supplementation with an array of oral tablets which are available: ferrous sulfate, ferrous ascorbate, the fumarate, the glycinate, the ammonium citrate, and a host of parenteral, some of them discarded in the present era, like the iron dextran, and some newer ones picked up very efficiently for improving the situation of iron deficiency anemia, as in iron sucrose, iron sorbitol, and ferric carboxymaltose. And when the time is limited and when the crisis is escalating, blood product transfusion seems to be the only option. Again, you would see the confusions in which iron given orally is the best, but at the foundation, at the background of it all is whatever you offer, you have to make sure of the patient compliance. One iron may be better than the other, but if it gives her the side effects and if she has the myths around the oral intake of iron, then you are back to square one. Amidst the usual players in the oral iron supplementation, ferrous ascorbate seems to reduce the ferric iron into ferrous, making the absorption thrice as much more and better than the other compounds. And when started early in pregnancy, we can hope that matching the WHO recommendations, every pregnant woman will carry a hemoglobin of more than 11%. There have been revisits in the oral iron in the past as well, because when the oral iron is recommended as the first line therapy in a cost-effective strategy to restore the iron balance, many times it doesn't respond and we resort to IV iron, but the quest for the oral iron continues. So the newer molecules which are encapsulated with the liposomes, the drugs encapsulated in the liposome, the liposomal drug delivery as we call, is as if we are protecting that molecule from being disregarded and fragmented in the gastric system, and it, with the capsulation, it will reach the intestine in a soft way, undisturbed and unfragmented, so that it can be well utilized when it moves ahead in the intestinal tract. Why the liposomal? Because it allows to overcome the free gastric environment, preventing early degradation. What next happens to this molecule is that it attaches to the M cells in the intestines. The iron salts like ferrous phosphorylate, when they're covered with liposome, the spherical structure of the phospholipidic nature, which is similar to the human membranes, makes it very much more friendly and the least adverse effect. So this has also been one of the new kids in the block, and there have been studies demonstrating that in about 8 weeks' time, indeed, there is a significant escalation in the hemoglobin level. The distinctive features of using the iron molecules, but wrapping them up with lysosome mechanism, such as the liposomal iron, high gastrointestinal absorption, higher bioavailability, better tolerated, and low incidence of side effects, makes it probably a choice which may be worthwhile before jumping into the parenteral iron. The bioavailability, if you see, of the controls compared to the existing ferrous fumarate or the ascorbate salts to the liposomal iron, there is a distinct difference proven by the evidence. The fact remains that if the pregnancy is in the mid-trimester or late trimester, we have very little time on hand to improve the anemia status, then the only resort is the parenteral injection, which makes us sure that it's getting into her system. And this was a study where 100 pregnant women diagnosed with moderate to severe iron deficiency anemia were intervened either with iron sucrose or with ferric carboxymaltose. And in both the groups, they saw that yes, the iron did escalate, the hemoglobin did rise, and the efficacy and safety is well proven beyond by many, many studies. However, the distinct advantage of ferric carboxymaltose is the patient does not require repeated visits. You will see the scenario in our own country, India, where hundreds of patients who queue up in the antenatal clinic are moderately or severely anemic, and they require a rapid infusion. And this is not an uncommon scene even today. The dosages that you would use, as I said, if it is ferric carboxymaltose, it is a single dose of about 1000 milligram as a bolus given slow IV over 15 to 20 minutes, whereas the iron sucrose, the maximum dose at one point in time that you can give is only 200 milligram, which also can be given as a bolus or an IV infusion, but the time span should not exceed 15 to 20 minutes. This could be given every alternate day or during her monthly visits for her antenatal care. If we have started this in the 4th or 5th month of pregnancy, there is enough time to give 200 milligram repeated dosages so as to cover for her requirements. So how does one calculate the repeated dose of iron sucrose? The formula may be looking complicated, but it is absolutely on a finger count. If she is at 8 gram percent and you want her to reach 11 gram percent, she is 3 gram percent short of the status of the pink of health. So every gram rise needs 100 milligram of iron sucrose. So 300 milligram is what this woman would require. Plus you add an additional 500 for the storage. So a total of 800 milligram needs to be given to a woman who presents with 8 gram percent hemoglobin. And this is to be done in divided doses of 200 milligram each. So 4 times the patient has to visit to make up for the total dose of 800 milligram. And this clearly is a disadvantage for accessibility and affordability issues, each time using a new IV set and the needle. The FCM given as a single dose has fared equally well or even better over a span of 2 to 6 weeks with a very quick rapid rise. So this seems to be the front runner in many of the institutes in our own country as of now. FCM has also a place in the postpartum period. There are many, many studies which have shown the safety and efficacy. And all of us should remember, when we say a pre-pregnancy care, it also means an inter-pregnancy care, because today the patient has delivered. In another year or two, she's going to come back with her next pregnancy. So the interval between this delivery and the next pregnancy also qualifies as a pre-pregnancy. So if you discharge her from the hospital, making sure that at least 1000 milligram of FCM is in her system, then at least in her next pregnancy, she will come back in the pink of her health. So the major initiative is called the T3 initiative. You have to test every woman, you have to offer affordable treatment, and you have to talk to sensitize the peer group as well as the community and the girls and women themselves, so that they realize that their health is in their hands. Never to forget the dietary advice. Besides all the foodstuff which are rich in iron, like the green leafy vegetables and the red meat that you would counsel them, please urge them to take the iron tablet with some citric juice, like a lemon juice or an orange, for better absorption. Make sure that you tell them simple points like not to have tea or coffee, because the caffeine and the phytates in the diet will interfere with iron absorption, and never to take the iron and calcium together. These simple counseling methodologies and testing and treating and talking to them will go a long way. A small step, but a big impact. So the 6 interventions which we plan in our country is, there are some endemic areas where the women do have malaria, and this needs to be treated if she has to consistently be sure of picking up her anemia status, and the iron deficiency should be plugged in. So the point of the care testing has now much become in the vogue, because at homes, at the camps, at the community centers. The testing can be done to whosoever lands up there. It does not require a grand laboratory setting. And this is one of the major innovative initiatives that we've taken. Prophylactic dosage for the deworming, because as much as malaria, the worm infestation also continues to be a menace. The prophylactic iron folic acid supplementation, which is now widely made available everywhere. So you give her the iron tablet, you deworm her, you check on malaria, you do the testing at every trimester to make sure that she is improving. If not, switch over to the injectable iron. Non-nutritional causes of anemia also needs to be kept in mind. And a simple initiative like a delayed cord clamping will help the next generation avoid the anemia. So in the Anemia Mukta Bharat guidelines, in our own country, the government has boldly introduced the use of parenteral iron as an IV sucrose or FCM as a first line of management in pregnancy if the anemia is detected late. And if she's severely anemic, they may be managed with hospitalization with the injectables. In severe cases, in the third trimester, the treatment done using IV sucrose or ferric carboxymaltose by a medical officer under supervision. But by and large, we found it to be very, very efficacious and also very, very safe. But in the guidelines, it says when she's close to the delivery, because the concept or the perception is that if we let her pick up her hemoglobin just before delivery, just in case she has a postpartum hemorrhage, she will be able to wait through that and we will be able to save her life. But dear friends, saving the women's life, yes, it is one of the important things. But if we ensure that there is adequate iron store and adequate iron circulating in her body by the start of the third trimester, 28 to 30 weeks, this is the best time when there is a peak transfer of maternal iron into the fetus, and some of the impact on the fetus, as in the nerve growth and the impact on the intellect and neurological development, would be great if we ensure that one way or the other, she is in the pink of health by the time she reaches the mid-pregnancy or steps into the third trimester. Optimal fetal, neonatal, and childhood growth and development require adequate iron, that is undoubted. And if we ensure this in a timely manner, not as late as end of third trimester, but in the beginning of third trimester, or better still, by mid-pregnancy, it would do a lot of good by reducing the low birth weight babies, abnormal cognitive development, increased risk of schizophrenia, which these babies have. It will save the next generation of all of these comorbidities. In a large study with a single dose IV iron formulation administered early in the second trimester of pregnancy to reverse the low birth weight and adverse outcomes because of the fetal impact, also is now being embarked in our own country, because that is the key point. That is where we need the maximal iron transfer to be ensured. Let me spend the next few minutes on the main theme. We have reflected on how anemia is a huge problem, even in terms of sheer numbers in the low middle income countries. We have also recognized that it has long-lasting impacts both on the mother and the fetus and the newborn. We have also discussed about how different formulations of oral iron moving in their journey to the parenteral iron and the time of infusions of these parenteral ions, the variety of co-strategies which have to be in place, as in the deworming, the nutritional advice, the protein supplements and the diet and the malarial treatment, etc. We are always in a quest for how easy, how affordable, how safe, and how efficacious can an oral iron be. And if we sensitize all our women that you've got to take this for a number of benefits that she may have, revisiting the molecule of lactoferrin, which helps regulate how well the iron is absorbed into the body from the intestine is worth reconsidering and renewing our thoughts in the fresh thinking. Well, most of us know that lactoferrin has a host of other activities. Besides the bone formation, anti-inflammatory, antimicrobial peptide chain, direct pathogen activities, the key thing in my focus of the further deliberation, where the other distinguished speaker will be speaking about all the other functions of lactoferrin and its impact on the immunity, let me just focus on iron absorption, iron sequestration, and inhibiting the biofilm formation, which is the key factor why lactoferrin is being considered in a bird's eye view to have its positioning in treatment of iron deficiency anemia across all ages. Lactoferrin is an abundant iron binding protein in the milk, and this bilobal glycoprotein, the complex but a colorful structure that you see on this slide, is present also in several other bodily fluids beyond the milk, and it's also present in the secondary granules of the neutrophils. The protein nutraceutical, as how it's been marketed, has two major forms, the bovine lactoferrin and the human lactoferrin. Bovine lactoferrin, if you could recall, the impact of ferrous sulfate, ferrous fumarate, ferrous ascorbate. Well, the bovine lactoferrin has the same efficacy restoring the iron deposits with significantly fewer gastrointestinal side effects. So that becomes a huge plus point for its use. The enteric coating allows the lactoferrin release some distance from the lactoferrin degrading pepsin, which are very, very active in the gastric geography, as we call it, or in the stomach, allowing the molecule to remain intact, just like how I had explained to you about the liposomal capsulation. And this is capable of binding the small intestinal lactoferrin receptors for the uptake and eventual transfer into the systemic circulation. So the lactoferrin purified from human and bovine are very similar, but not exactly identical. The question arises, therefore, that if the main transport mechanism of iron into the system is by transferrin, what is the function of lactoferrin? Both these proteins, the transferrin and lactoferrin, share similar iron binding properties, yet lactoferrin does not appear to be so important for the iron transport in our bodies, because we have constantly been referring to transferrin instead of lactoferrin, measuring the transferrin in the iron profile as well when we test many of our patients for the iron binding capacity, the red cell width, as well as the storage forms of iron such as ferritin. We often ask for the lactoferrin serum transferrin test, but we don't often ask for the lactoferrin. So the original ideas focused on the notion that lactoferrin, which is present in large quantities in human milk, played a pivotal role in providing iron to the nourishing of the newborns. This notion gained further credibility when lactoferrin receptor proteins were discovered way back in 1988 and re-endorsed in 2011 as well when we revisited this molecule. However, the structure of these lactoferrin receptors, also known as intellectins, very different from the transferrin receptors. So these two, the transferrin and lactoferrin, are clearly different. They may be achieving the same goal of transporting the iron, but they have different receptors, different structures, and perhaps different roles to play. So the notion that the lactoferrin can enter the cells and influence various intracellular pathways is now widely accepted by most of those who are working specifically in this field. While lactoferrin and transferrin both have the same global structure and use the same ligands for binding the iron, lactoferrin actually binds to the iron slightly better than transferrin at low pH values. The strong iron binding potency of these two proteins create a local iron deprivation. This has a fantastic mechanism of preventing the bacteria from growing, because the bacteria are deprived of their rich food with iron and they cease to grow. So lactoferrin, a protein that is packed with the double punch of improving the iron and the immunity, is what is being deliberated in today's discussions. The thought process then further continues that if we fortify the milk with lactoferrin, does it have a positive effect on the hemoglobin and the iron status, not only of infants, but also the adults? The hypothesis of one of these studies done by Passiano et al. Was that lactoferrin may have a comparable efficacy to ferrous sulfate therapy, but with more tolerability and fewer side effects. And the research question in that study was whether we can re-explore, revisit, and rethink about positioning oral lactoferrin as an effective treatment for iron deficiency anemia. And that's where we are coming from, compared to the traditional ferrous sulfate therapy. And if the hemoglobin rises very good and the side effects are the least, then this would well qualify as a frontline runner for the oral supplementation in cases of iron deficiency anemia. Lactoferrin, as we said, has an excellent affinity for iron with a constant balanced dissociation, KD as it's called, of approximately 10 to 20, and is required to maintain a regular iron harmony to eliminate the iron deficiency and iron overload. Oral delivery of bovine or human lactoferrin is effective in preventing anemia. Therefore, it can be a significant iron source for this group of women. This is a complicated slide. We won't even get in there. Suffice it to say that lactoferrin is responsible for having a high affinity for binding to iron, transporting it where it's needed, and releasing it for better absorption from the intestine. Coming back to the lactoferrin found in human milk, the colostrum contains 7 times more lactoferrin, and that's why as clinicians we always encourage the breastfeeding within 1 hour of birth, and we always say that colostrum is the best start for life. Lactoferrin helps to regulate how well the iron is absorbed from the body, and in another study of 300 women in different trimester of pregnancies, comparing again the ferrous sulfate to the lactoferrin, it was shown that after 30 days of oral administration of bovine lactoferrin, the hemoglobin and total serum iron values increased, and increased to a greater extent than observed in women treated for the same 30 days in the other arm with the ferrous sulfate, independent of the trimester of pregnancy. So no matter when you give them, the influence on the iron hemostasis directly or through other proteins is the key role that lactoferrin plays. This was way back 2 decades ago, and the same group continued to study this molecule even further in depth, and the studies in 2010 re-demonstrated safely and efficaciously we can use the oral administration of 30% iron-saturated bovine lactoferrin in pregnant women suffering from iron deficiency and iron deficiency anemia, which is the case in most of the LMICs. The increasing hematological values by the bovine lactoferrin is related to decrease of serum IL-6 and increase of serum hepcidin detected as prohepcidin, whereas the ferrous sulfate has the reverse impact. It increases the IL-6 and fails to increase the hematological parameters and prohepcidin. This is where the inflammation part of it plays a role, where the iron deficiency can be due to an inflammatory anemia as well. This slide shows that following these thought processes and the mechanism outlined, the iron-binding glycoprotein called the lactoferrin, abundantly found in the human and bovine milk, is emerging as an important regulator of systemic iron hemostasis. Several studies through the years to prove this fact, to bring this molecule into the forefront. There have been systematic reviews and meta-analysis as well. And within 4 weeks, the jury was in favor of the daily oral lactoferrin rather than the oral ferrous sulfate or ferrous ascorbate and other molecules. The results of all of these numerous studies indicate that diet supplementation with lactoferrin, which is an iron binding protein, may be advantageous in the prophylaxis and the treatment of iron deficiency anemia. When administered orally, it does normalize the iron hemostasis, not only by facilitating iron absorption, but also another prong of attack, interesting prong of attack, is by inhibiting the inflammatory processes responsible for anemia of chronic diseases. That's where it clearly scores over the other oral iron preparations. Characterized by a functional iron deficiency in the local region for a physiological process where the bacteria cannot thrive. So lactoferrin, dear friends, is a new generation oral iron that has been recognized as a member of the transferrin family of proteins and an important regulator of free iron with the ability to enhance the iron binding. And all the preliminary evidence suggests undoubtedly that lactoferrin may represent a promising new strategy for oral iron replacement. Lastly, coming to the anemia of inflammation, it was tried as against ferrous sulfate in anemia of inflammation in pregnancies with hypertensive disorders, where the impact on decrease of serum IL-6 and hepcidin, as mentioned earlier, this aided in improving the hematological parameters. It was found that bovine lactoferrin was also efficient in treating anemia of other pathological pregnancies and chronic diseases. So taken all these results together, the benefits and efficacy than the standard oral management with other oral iron preparation, lactoferrin is considered as a promising compound. The findings also suggest that not only in adolescence and pregnancy and beyond pregnancy, but it facilitates iron absorption even in young infants, as we all pledge that throughout the life course and life cycle, we have to focus and discard the menace of iron deficiency anemia through the generations. And because of the high affinity, the safe way to provide iron to infants in low-income countries where iron fortifications otherwise can adversely affect the gut microbe and cause diarrhea, this problem is eliminated by using the lactoferrin instead of the regular iron for the fortification. Lactoferrin has also recently come under spotlight. When I say recently, the recent ambience is all of COVID infection and the new COVID pandemic, right from 2019, has brought to light that lactoferrin has important immunological properties and is both antibacterial and antiviral. In particular, there is evidence that it can bind at least to some of the receptors caused by coronavirus and thereby block their entry. This is another interesting angle, and we intend to have more evidence and translate all these evidences into experience. We have to create a continuous buzz to the community as well about anemia as such. And another massive advocacy program going on in the country is the radio jingles and the radio bites. We are embarking on a massive training program of all the frontline healthcare providers through the digital platform so that they test, they treat, and they talk about anemia and pledge to make their practice anemia free. So the girls and women in schools, colleges, pre-pregnancy, during pregnancy, beyond pregnancy, at every touch point, we have to ensure good health and well-being for all, and everybody, just about everybody, has a key role to play both in the access to healthcare and access to affordable strategies to prevent and manage anemia. So in keeping with the SDG goal, number 3, which says good health and well-being for all, the targets are not only the pre-pregnant, pregnant, and post-pregnant women, but also the children under 5 years, both of whom can immensely benefit if our policies and programs and research projects bring into the forefront the new molecule for consideration, revisiting, and fresh thinking about lactoferrin for the benefit of all. Thank you again for your kind attention. And we are here during the last lap of this program to answer your queries, if any. Namaskar.
Hello, good morning, good afternoon, good evening. My name is Michael Auerbach. I'm in practice in Baltimore, Maryland, but clinical professor of medicine at Georgetown University, School of Medicine in Washington. Today, I'm going to speak to you about a new paradigm for the treatment of anemia in pregnancy, and I will try to intertwine some data on lactoferrin, the subject of this conference, to make my presentation more meaningful. It is important to know the difference for the need for oral and intravenous iron. I do think from the data that I have seen, lactoferrin may change the horizon for the use of oral iron. You should be familiar with all of the IV formulations. I do not wish to be disrespectful, but the use of iron sucrose throughout the world is suboptimal, and one of the reasons that intravenous iron has not taken place. 4 formulations are available today which allow complete replacement in 15 to 60 minutes. You should be able to differentiate minor infusion reactions with IV iron and the extremely rare hypersensitivity which can lead to anaphylaxis. It's actually more common with penicillin, and I'm going to show you a video which I think you will find amazing and enlightening as it applies to these reactions. Now, we're going to review some evidence-based treatment approaches with iron supplementations. Oral iron was really first used around 1500 when Sydenham put cold filings, iron filings in cold wine to treat the green sickness, which was then later described by Lang. Blaud renamed it chlorosis in 1832 and was the first to use ferrous sulfate. By the time the American Civil War, and I apologize for being xenophobic, came along, iron was used to treat war wounds. Today, iron deficiency is the most common micronutrient deficiency on the planet, estimated to affect more than 35% of the world's population and greater than 50% of gravidas. That's 3 billion people. It's 100 times more prevalent than all cancer combined. And here we are, 600 years later, using the often ineffective and poorly tolerated oral iron as our front line. Perhaps this conference will change that position. More importantly, using the World Health Organization criteria of years lived with disability, in every country in the world, iron deficiency is in the top 5. It's number 1 in lower and middle income countries and is the leading cause of years lived with disability in 35 different countries. Staggering and unappreciated. I'm showing you this slide because it's data that I recently published with my colleague Carlo Bruniera at Harvard. The reticulocyte hemoglobin, or the reticulocyte hemoglobin content, comes off on an autoanalyzer. The reason it is so relevant to this discussion is many Indian autoanalyzers have this iteration. It actually allows you to know if a patient needs iron within 40 seconds when the hemoglobin comes off. If it's low, whether the decrement is due to iron deficiency or anemia of inflammation, iron is necessary. You can wait for the percent transparent saturation in serum ferritin, which will take a couple of days. But if the reticulocyte hemoglobin content is low, you are ready to roll with iron treatment. Here is the data from our study, and you can see that a baseline reticulocyte hemoglobin content of greater than 28.5 or a hemoglobin of 10.3 clearly tells you whether or not you're going to have a response to intravenous iron therapy as opposed to less than 28.5 or 10.3. This is incredibly helpful in the treatment of iron deficient patients, especially if you are seeing a lot of them. To conclude about this, the reticulocyte hemoglobin content of 30.7 identifies iron deficiency using parallel ferritin and TIBCs with a 68.2 sensitivity and 69.7 specificity. And the prediction of response, a baseline retic HE of less than 28.5 has an 84% sensitivity and 78% specificity for need for iron. Something is making my slides jump. I would like that to stop if possible. Anyway, let's move on to the diagnosis of iron deficiency and some of the signs. Please always look at the fingernails of your patients. These are actually quite prominent. You don't see them this prominent that often. They're called koilonychia. But if you take a magnifying glass, which I have in my examination room, you can see these horizontal lines, which are analogous to rings on a tree, dating the iron deficiency for you. Always look at the tongue. It might even be a good idea if you have a mirror to look at your tongue right now, and you will see that the tongue is covered with white papillae unless you're iron deficient. Look at this woman's tongue. It looks like it was sandpapered. I don't know if you can see my arrow, but on the left side of the screen, you've got a few papillae left and the rest of the tongue is bare. Here is a patient who had a tongue like that and received intravenous iron. And I picked this woman on purpose. Look at all the hemangiomas at the front of the tongue. This poor lady had hereditary hemorrhagic telangiectasia. Oral iron has no role in these patients. There's no credible expectation that it will keep up with losses. And here we have a nearly completely papillated tongue. This woman has had hundreds, and that's not an exaggeration, infusions of intravenous iron. So now let's go to when you need oral or when you need intravenous iron. And I do want to say that I made this slide before I read the lactoferrin data. For mild, uncomplicated iron deficiency in the absence of active bleeding, in the first trimester of pregnancy or in the second trimester of pregnancy, if the hemoglobin is greater than 10, if taken and tolerated, oral iron is fine. It looks as if the tolerance for lactoferrin is superior to ferrous sulfate. However, in anyone who is intolerant or unresponsive, in the second trimester, if the hemoglobin is less than 10, because none gets to the baby, and I will show you that. In the third trimester, at any time, because none gets to the baby, after bariatric surgery, in which iron has to be conjugated to vitamin C, amino acids, and sugars in order to be protected from the massive alkaline rush in the pancreas, which converts it to the unabsorbable ferric hydroxide. With abnormal uterine bleeding, where there is simply no expectation that you'll keep up with the losses, And I really should change that to heavy uterine bleeding to use the more modern terminology. In inflammatory bowel disease, where oral iron actually makes the inflammatory bowel disease worse, directly toxic to the intestinal epithelium. And it also alters the microbiome, predisposing to an incommodious growth of the wrong bacteria. In angiodysplasia, which I showed you, and in any comorbid condition, which we call iron-restricted erythropoiesis. Now, adverse events with iron supplementation may not apply to lactoferrin, but prior constipation, metallic taste, nausea, gastric cramping, and thick, green, tenacious stool were reported in greater than 70%. The incidence of adverse events with lactoferrin is still higher than with intravenous iron. We have to talk about the side effects of IV iron, which I'm going to show you live. There's a minor infusion reaction that was actually described by Steve Fishbane, but published by me in my Lancet review in 2007. It occurs with pressure in the chest, headache, or flushing. It occurs quickly. It's harmless. It's self-limited. But unfortunately, throughout the world, because the teaching that intravenous iron is dangerous, this minor reaction is often treated with epinephrine or other vasopressors and antihistamines, converting this self-limited minor reaction into a serious adverse event. Now, when I say serious hypersensitivity, I don't mean with IV iron. I mean with any intravenous formulation. If you're going to give IV medicine, be prepared to treat pending anaphylaxis. It's less common with IV iron than with penicillin, occurring in fewer than 1 in 250,000 administrations. Here is a paper that did not include lactoferrin, published in PLOS One by Tolkien et al. In 2015, looking at randomized controlled studies comprising more than 5,000 patients. And as you can see, all of the gray boxes are to the right of the unity bar, which favors toxicity with oral iron. The number actually comes to approximately 70%. The OBGYN literature says that side effects with oral iron are unacceptably high. Now, here is an excellent paper in the Journal of Maternal, Fetal, and Neonatal Medicine, published by Darwish in 2018. As you can see, at 4 weeks with ongoing lactoferrin, there is equivalency or non-inferiority when compared to a total dose infusion of low molecular weight iron dextrine. And the authors are to be congratulated for choosing this marvelous way of giving intravenous iron, as opposed to the multiple doses of iron sucrose or ferric gluconate. What you can see is the pretreatment ferritins were low. At 4 weeks, they were significantly better in the IV iron arm. However, a ferritin of 60 with lactoferrin is not at all something to scoff at. I think these authors are to be congratulated. Here is one of the reasons that we have folklore about IV iron in pregnancy. A paper by Niaji, published in the incredibly prestigious Lancet in 2019, concluded that oral iron was equally effective. They stopped the study due to futility. The dose of intravenous iron sucrose given as 200 milligrams in 2 infusions was homeopathic. This is well below the recommended dose of 1,000 to 1,500 milligrams done properly by the Darwish study I just showed you. And this is the type of data which fuels the folklore, causing the suboptimal use of this necessary intervention for the treatment of one of the commonest maladies on the planet. There is a new paradigm for the use of oral iron. It comes from the laboratory of Michael Zimmerman in Switzerland, and it shows the importance of alternate day dosing compared to daily dosing. And the reason is simple. When you give iron once a day, as you see in this paper published in the prestigious Lancet Hematology that I had the privilege of writing an accompanying editorial, that the difference in absorbed iron with once a day or twice a day is virtually identical. But the serum hepcidin goes up with the consumption of an iron tablet. Here you have consecutive dosing for 14 days versus alternate day dosing for 28 days, an identical amount of oral iron. And in this study, in the same paper, you can see that the improvement in absorption is 30 to 40% higher with the alternate day paradigm compared to daily, with a 30 to 40% reduction in gastrointestinal perturbation. Here's the graph showing you the alternate day dosing of 60 milligrams of elemental iron, increasing the fractional and total absorption by 30%. And here's the reason why. What a gorgeous graph. This was not in the paper. This was sent to me by Michael Zimmerman. And I am so grateful. Take a look what happens when you swallow an iron. The hepcidin goes up for 24 to 48 hours. This question mark looks like it's 48 hours, and Michael will be coming out with new data this year. So when the hepcidin goes up, iron absorption goes down, and the hepcidin goes down, and iron absorption goes up. Here you have the incremental absorptions with a 35 to 47% increment in absorption with alternate day dosing compared to daily. Sadly, we don't have this data with lactoferrin, but hopefully it will come out this year. Now let's move on to the safety of intravenous iron. This study, published in Mayo Clinic Proceedings by Avni et al., looked at more than 10,000 patients. 4,000 were treated with oral iron, 1,300 with no iron, 3,300 with placebo, and 155 with intramuscular iron. Now, if what I'm about to say offends anybody, I'm afraid that's simply too bad. Intramuscular iron is painful, requires multiple injections, stains the buttock, has been associated with sarcoma, and should never, ever be given to anyone at any time for any reason, anywhere on the planet. Otherwise, I have no opinion about that. Overall, there was no increase in the risk of severe adverse events with IV iron compared to control, and there was no difference in either efficacy or toxicity among the formulations. And that means compared to control, which is sometimes placebo, there was no serious adverse event signal with IV iron. Infusion reactions occurred, but I'm going to show you how to deal with those. Now, let me tell you the story of this video. I don't know how many of you are part of our rapid iron study that is being done in Karnataka and Jaipur. It is a privilege to be working with Hema Divakar in that study, and she is one of the principal investigators. I was supposed to go to India to teach the doctors, nurses, and ASHAs how to deal with intravenous iron in the minor infusion reaction. I don't have to tell you what COVID has done to worldwide and global clinical research. Forgive my coffee. I got up at 5:30 in the morning for this. Anyway, it's still a privilege. Dr. Richard Derman, the principal investigator of the study and dean of global affairs at Thomas Jefferson University in Philadelphia, hired a professional videographer so we could demonstrate how IV iron is given. And with incredible fortune, after years of working with intravenous iron, I was able to film a live reaction. Here is a bag of theramoxetol. It doesn't really matter which formulation is used because they all cause this reaction with similar frequency. The intravenous iron starts slowly. This is my infusion center in Northeast Baltimore. Everybody's wearing a mask to ostensibly protect against infection. And here you have a young lady who has none of the risk factors for an infusion reaction, meaning multiple drug allergies or asthma or prior minor reaction to IV iron. Our nurse, Sarah, is starting the infusion. The young lady's mother is sitting next to her. And as you can see, the infusion starts very slowly. For those who do have risk, we pre-medicate with methylprednisolone and ranitidine, but not antihistamines because these are tryptase negative reactions which are mediated by complement. And antihistamines can cause hypotension, somnolence, tachycardia, diaphoresis, and misleading the practitioners to believing that it's the iron causing the reaction. Look how comfortable she is. This infusion reaction is going on, and this is this little pause here is vexing for the talk, but now you can see the reaction just occurred. Look how red her face is. Look at her eyes. You can see the tension. All right, she is complaining of pressure in the face. The pulse went up a little bit, the breathing went up, but there is no stridor, wheezing, or shock, and no periorbital edema. This is a minor infusion reaction. This is not anaphylaxis, and we did not set this up. This happened coincidentally with the video. The nurses are giving methylprednisolone and famotidine. The mask is now down below the nose because the mask makes people miserable and it's harder to breathe. And now the infusion has stopped and the methylprednisolone is being given. Here we are 3 minutes later. Look at the change in the color. She's so upset that she's on her cell phone. Now virtually completely comfortable. Sometimes these last longer. Come on, honey, smile for me. There we go. Now, the important thing, the most important thing, which is right here. I don't know if you can see my arrow, but this young lady received the total dose of the formulation that caused the reaction. This is what fuels the folklore of iron danger. The mismanagement of these reactions, in my opinion, is responsible for the overwhelming preponderance of serious adverse events ostensibly attributed to intravenous iron. Now, these are the available formulations. Low molecular weight iron dextran, I do not believe is available in India. Ferric gluconate and iron sucrose are. Theramoxetol is not. Ferric carboxymaltose is. And ferric dirisommaltose is. The key here is all of these have similar efficacy and similar toxicity. However, only low molecular weight iron dextran, theramoxetol, ferric carboxymaltose, and ferric dirisommaltose can be given as a single infusion of the total dose, which was done in the Darwood study in anywhere from 15 to 60 minutes. Dextran's an hour, theramoxetol's 30 minutes, carboxymaltose and dirisommaltose 20 minutes. This screams for the proscription of iron sucrose and ferric gluconate in the outpatient setting. They have no safety, efficacy, or cost advantage and should be proscribed. These are the way the drugs are approved in the United States, but we give all of them differently. Ferric carboxymaltose, unfortunately, comes as a 750 milligram vial. So to give a gram, you have to waste 500 milligrams. It's unfortunate. The others can all be given between 15 and 60 minutes. Very briefly, I want to take you through why intravenous iron works. I think all of you know that hepcidin is the iron regulator. It facilitates the transport of iron across the intestinal epithelial cell so it can be exported onto the transferrin receptor and delivered to the bone marrow. Hepcidin blocks the export protein ferroportin in both the intestinal epithelial cell and the macrophage. When it's up, iron absorption and utilization goes down, and when it's down, it goes up. In inflammation, in chronic kidney disease, in cancer, in morbid obesity, hepcidin is high. We do not have in vitro data for this slide, but when you give intravenous iron, it immediately saturates circulating transferrin and does so as long as it's in the circulation. The exact time is not known, but it's estimated to be 4 to 8 weeks. The circulating macrophage is very iron avid and acts as a reservoir. When iron gets into the macrophage, which cannot happen with oral iron because of the hepcidin block, it upregulates two proteins, iron regulatory proteins 1 and 2, which then upregulate ferroportin, overcoming some of that block. And while it's not proven the clear benefit in the reduction of ESA usage in chronic kidney disease and chemotherapy-induced anemia, a supply provides support for these hypotheses. Now let's move on to pregnancy, the subject. Children of iron deficient mothers have an increased risk of being born iron deficient. We don't screen newborns around the world. It borders on ridiculous. We screen for phenylketonuria, which occurs in 1 in 25,000, but not for iron deficiency, which occurs in 1 in 4 at a level associated with neurodevelopmental delay. Iron deficiency in mothers is associated with an increased risk of preterm labor, low birth weight, and child and maternal mortality. And the current ACOG and United States Preventative Services Task Force and the Indian guidelines largely ignore these data. Iron deficiency is not unique to lower and middle income countries. There's virtually no white on this map. Wealthy Western countries, countries with moderate incomes, and lower and middle income countries have an extremely high incidence of iron deficiency. It is important to recognize that anemia in pregnancy is a significant health issue affecting more than 50% of gravidas worldwide, and the guidelines differ. You will forgive me, I work in the United States, but I think you can take these tenets and apply them globally. The United States Preventative Services Task Force says there is insufficient evidence to support the routine screening and supplementation of iron in the absence of anemia. It's simply incomprehensible how anyone can make that statement based on the data I'm about to show you. The brand new ACOG practice bulletin moved forward that says intravenous iron is recommended in those who cannot tolerate or will not take modest doses of oral iron, but they recommend ferric gluconate, the one formulation that we specifically prescribe in the section anemia in pregnancy for up to date, which I have the privilege of writing. The 2019 United Kingdom guidelines are much more proactive. Parenteral iron should be considered from the second trimester onward and during the postpartum period for women with confirmed iron deficiency who fail to respond to or are intolerant of oral iron. A marvelous paper in Blood by Maureen Achevi and Anat from Harvard and Anat Gafrazavili from Israel said that IV iron should be given to any oral intolerant second or third trimester patient, and for second trimester gravidas with hemoglobins less than 10.5, and everyone in the third, and I'm going to show you why. To date, all over the world, there is no guidance for non-anemic, iron-deficient pregnant women, despite the proof of danger. These are the requirements in a normal pregnancy. Around the first trimester, it's about the same as the non-gravid state, but there is dramatic 5 to 12 time increment as you get to the second and third trimester. Considering absorption, there is no credible expectation that when you get to an iron deficient woman in the second trimester or all in the third trimester, that you will provide an adequate amount of iron to the developing fetus who so desperately needs it for normal brain development. Maternal iron deficiency potentially affects fetal, neonatal, and childhood brain growth and development with adverse effects on myelination, neurotransmitters, and brain programming. These are all published in high-quality neonatology journals. Children born to iron-deficient mothers demonstrate lower cognitive function, memory, and motor development, which you can recognize up to 19 years of age. Iron deficiency in pregnancy has been associated with an increased risk of adverse perinatal outcomes, including preterm birth, low birth weight, and small for gestational age infants. And our rapid iron study that I'm doing with Dr. Divakar is hopefully going to show how we can obviate much of that. There is a reduction in fetal iron status when the mother's ferritin is less than 15 in the high-quality Journal of Nutrition. Prenatal iron supplementation reduces maternal anemia, as I showed you in the slide from the Darwish paper with lactoferrin. However, iron deficiency was found in nearly 50% of the babies who were screened with cord blood at birth, despite oral iron supplementation. Here you have a slide given to me by Michael Georgiev, published in Pediatric Research 15 years ago. Michael refers to the purple box as the period after which you cannot overcome the deficit. And this is from week 32 of gestation to 2 weeks postpartum, following which all of the morbidity that I described in the previous slide continues out to age 19 years. Here you have an incredible paper that was published in 2019 by Wigiersma et al. In the prestigious JAMA Psychiatry. And what you can see in these slides is that at any week of gestation, anemia was associated with a statistically significant increment in autism spectrum disorder. And while you might criticize me by saying we didn't, this paper didn't describe the cause of anemia, you know as well as I do that the overwhelming majority of anemic gravidas are due to iron deficiency. This paper should make your hair stand up. The risk of maternal mortality in women with severe anemia during pregnancy was shown in a multi-level analysis published by Darrow in Lancet Global Health with an odds ratio of 1.86. It is time for us to make this a primary and important issue worldwide. Infants at risk for neonatal iron deficiency are those from iron deficient mothers or who were previously treated with iron deficiency, underweight or overweight, vegetarian, multiparous, mothers with inflammatory bowel disease, HIV, with an interpartum period of less than 6 months, or with a history of heavy uterine bleeding. Why on earth can't we just say everyone? Here's the slide I told you about, and this is terrifying. This comes from the Shao study. These mothers were supplemented with oral iron. And sadly, I do not believe lactoferrin has the ability to overcome this, because this has to do with transplacental transfer from the mother. As you can see on the left, there was virtually no improvement in the baby's ferritin levels at birth when the mothers were iron deficient and supplemented with oral iron. Excuse me. This is a slide from Michael Georgiev from the University of Minnesota Department of Neonatology. It's a scary slide because low iron intake during critical periods of pregnancy increases specific types of neurodevelopmental risk. Schmidt et al. Described autism in the first trimester, incel schizophrenia in the second, and abnormal brain growth and matter complexity in the third trimester. But there's a huge overlap with all these three. It's a disturbing slide. This is data from my group. We looked at 104 consecutive non-anemic, can I underline that word, non-anemic, presenting gravidas in the first trimester, well women. And we did the iron studies that the United States Preventative Services Task Force says there's insufficient data to recommend. Take a look at these data. 42% were iron deficient based on TSAT, ferritin, or both, and it didn't matter until you got to gravida 4. Every single presenting mother should have iron parameters checked. These women would all have been missed using the current paradigm. Here you have it stratified by gravidity. You can see gravida 1, 2, or 3 didn't matter. Gravida 4, it was even worse. These slides are available. Please feel free to use them. A marvelous study corroborating what I just showed you was published by Teichmann et al. And presented as a best of ASH in the 2020 American Society of Hematology annual meeting. And this shows you the prevalence of iron deficiency among Canadian women in a huge cohort. And if you take a look, almost 50% were ever normal. It's an incredible number. Here you have the results when iron deficiency is screened early. These results are staggering. Look how the increase occurs throughout gestation. Virtually none are normal. Iron deficiency affects greater than 50% of pregnancies in Ontario, Canada. 25% are complicated by severe iron deficiency, and 40%, as I showed you, are not ever screened. We need a worldwide change in our approach to this ubiquitous problem. The implications for clinical practice are enormous. Based on their findings, the ferritin test should be routinely done as part of the first prenatal visit. However, failing to evaluate iron stores in the second or third trimester is an even worse problem, missing periods with the highest risk when IV iron is necessary. These important gaps in care should be addressed by revisiting our obstetrical guidelines to recommend routine testing in pregnancy, and optimal timing and frequency of screening remains to be determined, but it belies common sense and dismisses recent data to not do it at presentation. This is a slide from Betsy Lozov's group at the University of Michigan, showing you the effect of iron deficiency in infancy on cognitive and performance. And you can see that good iron status is associated with excellent results, but as you get chronic and severe, the results go down. We're looking at 17 years of age. Here you have motor coordination in the iron deficient toddler. And in iron deficiency, there's a clear decrement. And then in non-anemic iron deficiency, it's still there. Can we underline that? Non-anemic iron deficiency, and look at iron sufficiency, this tiny group at the bottom. So in pregnancy, you have treatment options. Up to 70% to whom oral iron is prescribed report GI distress. If lactoferrin overcomes that, it might become a new standard. As I told you before, the GYN literature reports an unacceptably high incidence. Numerous publications have reported the safety and efficacy of IV iron when used properly, but there exists a folklore of danger which inhibits its use, and it is also inhibited by the ill-considered use of iron sucrose and ferric gluconate, which require multiple injections compared to a single infusion. It is this misperception that fuels the folklore of danger. Here is a study from my group. It was the first prospective study ever done in the United States, and you can, there's no comparative because FDA wouldn't let me because I had to include only iron, oral iron intolerant women. But look at the p-values, 4 and 5 zeros for hemoglobin, TSAT, and ferritin. No way you would achieve this with iron, with oral iron. And here you have a different study done by Myers et al., comparing ferric carboxymaltose and low molecular weight iron dextran. Identical results, no increment in side effects, and no difference in adverse events among the two formulations. Here you have postpartum anemia, published in Vox Sang by Charlotte Holm from Denmark. And as you can see, using primary outcomes of fatigue, a clear benefit of intravenous iron. Here you have fatigue and depression, clear benefit for intravenous iron. And here hemoglobin and ferritin, a marked benefit for intravenous iron compared to oral iron. So what I've showed you, these results support the convenience, safety, and efficacy of the single infusion of intravenous iron. We believe IV iron should be administered as soon as oral iron intolerance occur, and to those in whom oral iron is ineffective or harmful that I told you during this talk. It is inconceivable to recommend that pregnant women not be screened for iron deficiency at presentation. It belies common sense and dismisses recent data. Compared with oral iron, and this does not include lactoferrin, intravenous iron has fewer side effects. And truthfully, it does have fewer side effects because there was still some gastrointestinal perturbation, although mild, and is nearly always effective. And based on published evidence, properly powered studies like we're doing in the rapid iron study in Karnataka and Jaipur need to now add lactoferrin to this study paradigm. What did I tell you today? Oral iron's front line in uncomplicated iron deficiency. I agree. Lactoferrin may provide a better alternative. High quality evidence suggests alternate day is the way to go. For those conditions where oral iron doesn't work, IV iron should be front line. The preponderance evidence suggests that the recommendations of the United States Preventative Services Task Force and guidelines around the world be dismissed, and iron deficiency should be looked for in every presenting gravida. You have 4 formulations. I'll say them again: low molecular weight iron dextran, ferric carboxymaltose, iron isomaltose, well, with ferric dirisommaltose, the name changed. I have to fix the slide. It was a WHO edict to change the name to dirisommaltose, and ferromoxetol provide a single infusion in 15 to 60 minutes, completely replacing iron. And intravenous iron is safer than you learn. I showed you that. And it's safer than most physicians believe. And the minor infusion reaction is just that. And if you're going to use IV iron, you need to know how to deal with it. Thank you for inviting me to this exciting presentation. I will take questions at the appropriate time.
Thank you, Professor Michael Auerbach, for your wonderful insight into management of iron deficiency anemia. And thank you, Professor Hema Divakar, Madam, for your wonderful insight into highlighting how iron deficiency anemia in each trimester has such deleterious effects on the newborn and the fetus and the long-term effects that it has on the baby. And it's so important that these anemias get screened at every trimester. However, I have a question for, for you, Madam Divakar. Uh, According to guidelines, we are asked to screen for anemia at only 2 visits, one being the booking visit, where the patient comes to us at maybe about 12 weeks, which is the end of the first trimester, and one at 28 weeks, which is at the end of the second trimester and the beginning of the third trimester. Do you think that we should be screening women at every trimester? And do you think that as a chair of Well Women Committee of FIGO, would you recommend that anemia be screened at every trimester?
Thank you, Amla. Thank you again to the organizers for the kind invitation. The gap between knowing and doing is really big. Everybody wants to screen and screen as many number of times as you want. But what are you doing about it is a more important question that one should ask themselves. And I would rather say that at every touch point, every girl, every woman need to be checked for the status of anemia, because even before she embarks into the pregnancy, that is the best bet that you can have. Early pregnancy, you have screened, you have plenty of opportunities to get into the corrective mode to get her into the pink of health. Well, there could be other things that you would see clinically, which will prompt you for an additional or an expanded kind of testing. And you would certainly feel free to do that. But once again, I emphasize, how are you making your practice anemia free? That is the key question. Do whatever it takes, but see to it that the next time you check, maybe next in 3 months' time or every trimester or whenever you want to do, you have to see to it that there is a forward movement of the needle as far as her hemoglobin and a couple of other investigations that you may choose to do.
Thank you. Thank you, Madam. My next question is to Professor Michael Auerbach. Sir, I believe we discussed this before the session began, but we encounter a lot of patients who are in the fear of iron overload, especially with thalassemia carriers. And we have to be very vigilant in starting any iron preparations for these people. So do you think, in your experience, that lactoferrin is an ideal compound that can be given to these women if they are found to be iron deficient?
I think if they're found to be iron deficient, it just clearly speaks the need for iron replacement. If it's going to be oral iron, from what I've read so far, it appears to be better tolerated. But there is no reason to think that a patient with thalassemia should not receive intravenous iron if the iron parameters report iron deficiency. You just have to be careful about the MCV because it's low in both.
Yes. Thank you.
I just have one small point to add, Amala,
Yes.
that in fact, when low middle income countries like ours cannot screen them a whole load into what kind of anemia it is, because beyond the iron deficiency, nutritional deficiency, there could be, of course, thalassemias and sickle cell and other group, where we cannot, in a practical setting, cannot do everything for everybody everywhere. So in fact, when you give lactoferrin and it doesn't improve, though the compliance is assured because of these side effects, then you give intravenous iron and it doesn't improve to the extent that you expect it to improve, then your mind starts thinking, am I missing something? Because if it doesn't go as high as expected, then you will probe into other related causes. And if it's thalassemia, then you know that there is a saturation point and you don't expect improvement after that. So it kind of filters your cases for additional investigations where the resources are poor. And as Professor said, there is no reason to hesitate to give the intravenous iron to plug and replace the iron deficiency as it exists even in thalassemias.
Thank you. Thank you, madam. And we have a few questions from our esteemed attendees who have joined us this evening. This question is from Dr. Yusuf Abu Elwan, and he asks that can we combine lactoferrin and elemental iron such as iron sulfate? Does it it gives better than is it okay to give it together or can be given alone? Can
I
it be
read in the chat
combined?
box that Michael wants to answer this live. So Michael, you go ahead and I will add my LMIC
No,
perspective.
I think that this is for you, Hema.
Okay.
I don't have your experience with it, so I can't see a reason not to, but at the same time, I don't see a reason to either.
Okay, so I'll go in then. Because see, there are 2-3 points that we have to consider. One is that we now seem to be having an overwhelming evidence that compliance with lactoferrin as a standalone is really good, and it reaches where it has to reach. It has multiple prongs of action where efficacy and safety both are established. So giving it alone should, in the normal course, give you better results. And the dosage is 100 mg twice daily. If she is dumped with more number of tablets, it will definitely add to the non-compliance, and the adverse effects of the other drug that you're giving might as well make her all or none. She says, I don't want to even take anything, and she may stop the whole lot. So it looks as though that if the best oral iron has to be given, go ahead and give one. Okay. If it doesn't work, and then you know that it's urgent to make it work, so you may resort to the parental. But just mixing up everything in the hope that it will give better results, in fact, you may be more at a disadvantage rather than an advantage. Please keep your mind open to the other associated causes, like how I said in India, the malaria and deworming, or there may be anemia of chronic origin, which you will need to open up your mind and think, just if this replacement is not helping, what else could it be, and get at the root of it. In fact, I would think that any one of us who is handling a case of abnormal uterine bleeding at any age should look at anemia as the other side of the coin, because these two are
Yes.
well as a exist in partnership, because there is loss of blood, and you will need to see what a hemoglobin status is. So at every touch point, every age, through the life course, keep thinking about it. And if more and more of you think and act, I think anemia should be a non-issue very soon.
Thank you, madam. Thank you. And there is a question from an anonymous attendee who thanks both you, Professor Divakar and Professor Orbach, for such a wonderful presentation. The question is for Professor Michael Orbach. What is your intake on sarcoma-induced intramuscular iron injections?
Okay, I need to be careful answering this because I feel so strongly about it. There are 2 reported cases. They're referenced in my review of intravenous iron in the American Journal of Hematology. But let's throw it out. Let's pretend sarcoma of the buttock is not caused by IV iron. By the way, I've been a doctor for 48 years and I've never seen one. These are the only 2 reported cases I've seen. IM iron is painful. It requires multiple injections, multiple visits. It permanently stains the buttock. It's not safer, it's not more efficacious, and it's not less expensive. It is flat out cruel, and you cannot make up a reason to use it. And therefore, I will keep my position that intramuscular iron should be absolutely proscribed.
Thank you, Professor. There is a comment from one of our attendees that they would like to have access to both your presentations. I would like to add that it is available on the YouTube channel that I mentioned earlier. Both the presentations are available for you to access, and the entire session is recorded live on YouTube. There is a final question from Dr. Majideh, who says, and it is for Dr. Hema Divakar. Madam, for how long can we delay clamping the cord for newborn to improve the health and prevent anemia in the newborn?
Okay, this is a very simple step with a very big impact. You have to see the cord pulsation, which will usually stop at 1 to 3 minutes interval. After that, you clamp the cord. If the baby has spontaneously cried, if not, you have to immediately clamp the cord, cut it, take the baby for resuscitation, etc. But delayed cord clamping, by which we mean 1 to 3 minutes when the cord pulsations have stopped, because even that extra inflow into the system of the newborn goes a long way in improving the status of the newborn as well.
Thank you, madam. We have questions coming up. I think everybody's typing in. The question is that, is there any precaution regarding the type of iron therapy during first trimester regarding fetal safety?
It's a marvelous question. I don't know. And for that reason, and exclusively that reason, we recommend that intravenous iron not be given in the first trimester. There's no safety data. I don't know that it's not safe, but I don't know that it is. And having treated 7,000 gravidas without a serious adverse event, the difference between 0 and 1 is high, and I would like to keep it that way. As for oral iron, I think it should be given every other day. It looks like lactoferrin's a good choice. I would avoid time-released formulations and enteric-coated iron because they are not absorbed adequately and they end up in stool.
But sir, I probably would rephrase this question a little bit in a clinical scenario. If you have a patient who is non-compliant with oral iron medication because of hyperemesis in her first trimester, and she has a very low hemoglobin, say below 9, and she's unable to retain any fluids, do you still not recommend intravenous iron therapy for such a patient?
It's a hard question. In my heart, it's probably fine, but we don't have safety data. I would certainly discuss it with her to weigh risk versus reward. I would be more appreciative if I could have some data that intravenous iron is safe in the first trimester. But your question's excellent, and sometimes you just have to take a risk, and I might do it if it was severe enough.
Okay, Amala, I just want to add again a very important point for the low middle income countries, that now there is a huge program nationwide going on the adolescent age group because we want to build them up to good health. So please see to it that before she embarks on the first pregnancy, that's point number 1. And many women whom you discharge from your institute, they would have perhaps lost some blood during the delivery. And we so much emphasize on the anemia in pregnancy, gestational anemia. Don't leave that window of the postpartum period to give her what she needs, either oral or intravenous, and build her up. Because as I said in my talk also, within a year or two, very, very typical unintended, unwanted pregnancies, she may well continue, but at least then she will be in better health. And thirdly, if you have not done either of these two things and you have missed the bus, then if it's 9 grammar, nothing will happen to her in the first 12 weeks. Most of our women, first of all, book in late. They may not just come in the first day of the missed period. They're closer to 12 weeks. So you might as well counsel her about the good diet and sanitation, hygiene, everything else that, the talking will take. And once she enters the second trimester, you can as well do the same things which you were planning 2 weeks earlier, for example, because anything that happens, if you are the unusual practitioner who is being adventurous in that phase, then you are sure to be blamed that everything is because of the IVN, and it may not be very ethical now anywhere in the world to do these studies for the safety parameters. So we would refrain from putting our step ahead in that small window period, but use the rest of the second trimester to really, really build her up for the very fact that we've said about the neurological implications.
Yes.
Well, if she hasn't turned up or you have missed there also, again, you have the last 3 months where if that's the only opportunity for you to do your best, then please do it.
Yes. Thank you, madam. Thank you very much. I think we've come to the end of our question session. I take this opportunity to thank you both profoundly for such a wonderful insight into managing anemia in pregnancy and even in non-pregnant patients. Madam Divakar, it is always a pleasure to listen to you. And Professor Michael Auerbach, it was an honor to host you, and I will be more than happy to host you physically in Dubai, madam and sir both, when the timing and the travel restrictions are laid down. It would be great to meet in person, madam and sir. Thank you very much for a lovely, lovely evening and
Thank
a
you.
wonderful session.
Thank you. Bye-bye.
Thank you so much to you too and the organizers. Namaskar.
I would like to tell everybody that the CME will be available in 14 days. Please fill out the evaluation form and answer the post-webinar quiz that will be sent to your registered email IDs to obtain the CME credits. The webinar is available for all of you to view on this following YouTube channel link, and you can access it through MCI YouTube channel as well. Thank you for attending the New Frontiers in Management of Anemia webinar, and I wish you all a very good evening and greetings from the Emirates Medical Association. Thank you very much.